The first speaker of this evening is Katie Longman. She is a PhD student under Professor Melanie Bailey at University of Surrey, UK. And Katie's interest in alternative sampling strategies began in 2018 whilst completing a placement year at Cambridge, and was based a drug testing company, Untitled Fingerprint, where she developed and managed clinical studies relating to that drug screening assay to detect illicit drugs in fingerprints. She worked on developing finger sweep technology using paper spray and liquid chromatography and mass spectrometry. Her current research investigates the feasibility of finger sweat analysis for medical adherence and therapeutic drug monitoring, with clinical studies relating to antipsychotic, tuberculosis, and anti-epileptic drugs. Katie, the floor is yours. And I think now I should stop share screen, right?
Thank you. Yeah.
Yeah.
Thank you for the introduction. Let me just load my slides. My name is Katie, and today I'm going to talk to you a little bit about drug analysis for using a fingerprint for medical adherence monitoring. So my supervisor Mel would have loved to have been here today, but unfortunately for us, but luckily for her, she's on holiday. So thank you for letting me speak in her place. So first of all, I'm going to talk to you a little bit about a fingerprint, what is it and what is it made of, and why we might want to use it for drug analysis. And then finally, I'm just going to talk you through how we as a group move from forensics towards medical adherence monitoring. So the current research is looking into, can we see if a patient has taken their medication, and can we possibly move towards looking for drug levels in a fingerprint. So first of all, natural fingerprints are made up of two different types of materials. So this is endogenous compounds, which are primarily from equine sweat. So we have amino acids, metabolites, salts, and we also have things from exogenous sources. So this might be from coming in contact, say, with maybe touching your face, and you've got like sebum or cosmetics, coming in contact with your environment, or coming in contact with other people. So traditionally, we use these components to look for things that we can capitalize on to enhance the ridge detail of the fingerprint, so that we can come up with the ridge detail and then identify a suspect. So that's really how we first got involved in this research. So our early work looked at using forensic casework and seeing how mass spectrometry could kind of supplement this. So we collaborated with universities, the police and industry to look in to see how imaging techniques using mass spectrometry could help. So one of the things that we worked on was secondary ion mass spectrometry. And what you do here is you just you fire an ion beam at a sample, and then analytes are sputtered back. And when these are sputtered back, you can develop an image of the thing that you're analyzing. So in our work, we looked at using these techniques to try and enhance fingerprints that couldn't be resolved using traditional techniques. So if you see down the bottom here, we've got a fingerprint. And not all of this fingerprint could be resolved using the traditional techniques that the police use. So using SIMS, we were able to analyze this area here and then get greater ridge detail. So starting out here from forensics, we thought, well, that's really interesting that we can look at fingerprints using mass spec, like what else can we do? So we were thinking perhaps we can look at differences in age, maybe differences in sex, and then finally, what we ended up focusing on, which is the possibility of drug use from fingerprint. Coming from this sort of like background where you're thinking about what are the positives of using something instead of blood, we think, well, you know, a fingerprint is fast to collect, like it only takes a few seconds to give a fingerprint. It's non-invasive, so you don't have the possibility of having to give a blood sample where you might have to ask a patient to use a needle or something like that. And also you don't need anyone that's trained to collect the sample. So a patient can collect the sample themselves and post it in. And that's another sort of thing that's really interesting to us, is that you could collect your sample onto a piece of paper, post this into the lab. This removes the need for hospital appointments, which would reduce burden on the hospital, and also reduce the need for the patient to always be coming in for appointments. So another thing as well that is that the fingerprint itself holds the identity of the donor in the sample. So you've got that ridge detail there to be able to link it back to the patient that has given it. So at Surrey, we've developed like a simple workflow to look at drug testing and fingerprints. And the first step is to collect the fingerprint onto some paper. So our collection devices are really simple. It's just a glass slide with a piece of paper fixed on top. The patient presses their finger down for a fixed time at a fixed pressure on this piece of paper. This piece of paper is extracted using a simple solvent, so we just use usually methanol. The paper is removed, the sample is dried under nitrogen, the sample is reconstituted and then analysed using a simple 3-minute LC-MS method. So starting out from the point of view of forensics, we first looked into using fingerprints for illicit drug testing. So in this study, we used people who had testified to use of heroin within the last 24 hours. This was verified using an oral fluid test. And in the study, we collected from 15 participants and collected all 10 fingers. So we had a sample from each hand, all 5 fingers. And we found that we could see the metabolite of heroin in all of these cases. So this was really interesting, but the first sort of thing that you come up against when you say, well, I've analysed the fingerprint and I can see a drug in it, is trying to say, well, how do you know the person has taken this drug? We've said that we can see the metabolite, and maybe that's good enough for some people, but really I've said that half of what you have on your fingers is from external sources and it's not exactly from yourself. So what we wanted to do was test the robustness of our test by looking at different sources of contamination and seeing whether that would our test would still hold up against these. So the 2 things that we looked at were everyday exposure, so just touching surfaces around you, and also contact with a drug user. To combat these 2 different effects, we decided that we were going to implement a hand washing stage. So we had 2 sets of people. The first just touched environment around them. The second shook hands with drug users. We asked them to wash their hands, after which we collected a sample. And after this hand washing stage, we were able to say that our test had 100% accuracy, sensitivity and specificity. So from here, we thought, well, where else can a fingerprint go? It's really interesting that we can use it for illicit drug testing, but where else might it be useful? So all of the things, the advantages that apply to illicit drug testing also apply for the monitoring of therapeutics. So we were thinking that we could perhaps use this to reduce burden in hospitals. So we decided to collaborate with different groups of people, looking at anti-epileptics, looking at anti-TB drugs and looking at antipsychotics, to see whether we can check if a patient is taking their medication, and also if perhaps we could develop some sort of drug level using a fingerprint to relate to how much drug is in a system. So the first sort of group that we looked at were antipsychotic patients. So here there's a real high incidence of people not taking their medication. So we collaborated with Surrey and Borders Partnership, NHS Trust, and we recruited participants who were taking different antipsychotics. So here they were taking clozapine, quetiapine, olanzapine and risperidone. And we found in our early results that we could detect the parent drug in all samples. And we also were able to see the metabolites of quetiapine, risperidone, and clozapine. So we were thinking about how we could enhance our testing. Where would this be able to go? Perhaps making a test faster would be more useful. Could we change our analysis method to try and make something that gave results in a quicker way? So one of the things that we explored was the use of paper spray mass spectrometry, where you remove the need for sample preparation by using an ambient method of directly spraying the sample into the mass spec. So this method takes about 2 minutes and doesn't require any of the sample prep that I discussed earlier. You collect the sample onto a piece of paper again. It's a triangle piece of paper shown here, and you can directly spray this into the mass spec and get a result within 2 minutes. So we looked at how else this might be useful. So we saw that you can visualize a fingerprint and also use it for paper spray. So in our work with cocaine, we saw that a fingerprint which had been developed on this piece of paper could then be sprayed directly into the mass spec to give a result. And we also thought about using it as perhaps a quick screening stage. So can you get a quick yes or no before we submit it for further laboratory analysis? So in this work, we recruited patients taking antipsychotic drugs. We analysed the sample first using paper spray, saved the sample, and then extracted it for LCMS, and were able to do a confirmation test to show that the result that we had achieved using paper spray was correct. One of the things that we also thought about was checking whether a patient could falsify this test. So in cases of antipsychotic drug misuse or not taking their drug at all, patients will try and cheat the system. So they might think that perhaps just coming in contact with the drug itself might be enough to trick our test. So we had a few people handle the drugs in different forms. So we had a group of people that touched the tablet itself and didn't take it. And we had a few people who crushed the tablet up and then touched the powder inside the tablet to see whether this would have an effect on the results. So in the graphs down below, we have people who have touched or taken quetiapine, and we've collected samples before and after hand washing to show the difference here. So what we did was we had 3 patients. So in like a dark red, an orange and a yellow, we have the patients who have taken their medication. And then we have in the blue here down the bottom, we have the people who have just come in contact. So we were able to see a clear difference in the people who had taken the drug as opposed to the people who have come in contact with the drug by doing a ratio of the metabolite to the parent drug. So the metabolite largely comes up in the people who have taken the drug and is not really seen in the people who have just come in contact. So this was really encouraging for us as we were able to see this both before and after the hand washing, showing that we could either have a quick test where we just take the fingerprints as presented, and this also holds up after a hand washing step as well. So all of the work that I've discussed so far is qualitative, and something that we're really interested in is working towards a drug level in fingerprints so that we can see how much drug is in a system. But one of our biggest limitations is in the sample itself and collecting the sample. So one of the things that we really struggle with and is well documented in the forensic literature is the inability to collect a reproducible fingerprint sample. It's really difficult to get the same sample from even the same person on the same day, never mind at different times of day from different people. And there's also the issue that you don't really know how much sample is collected. So for other HCs, you have a volume that you can use. For fingerprint, it's so small that you don't really know how much is there. And in some cases, it's really hard to know whether there is even enough drug or even enough sample to do this drug test. So we worked a little bit in the lab to try and see whether we could improve how much sample we were getting, or at least make our sampling efforts a bit more consistent. So in this case, we decided to look at a marker that is in equine sweat, which is creatinine. And we tried to see how this marker would change depending on the collection technique that we used. So we had 3 recruits, and we asked them to sample in 4 different ways. And we changed the amount of time. So we had 1 finger for 10 seconds at 1,000 grams, 30 seconds at 1,000 grams, and 60 seconds at 1,000 grams. And we also asked them to do one where they use all 5 fingers on top of each other. So Intelligent Fingerprinting, the company I work for in my placement year, they asked for a person to put all 5 fingers down on the same sample just to maximize how much sweat you're getting. But we've decided in our work that instead of having all 5, we would really like to just keep it to 1 finger, because that makes it a lot more simple and also a lot more useful if you want to look at the ridge detail. So here we have all 5 fingers on top of each other, and you can see that there's a bit of variation here between different people. We have 10 seconds, 30 seconds and 60 seconds. And what we did with this is we timed it, but we used a kitchen scale. So we try and keep everything as accessible as possible. So we just ordered a kitchen scale off Amazon and used that to control the pressure. And we found that increasing the amount of time did improve the amount of sweat that we were able to see. but I don't know if you've ever counted like 30 or 60 seconds with someone when there isn't much that you're doing, but it really dragged out, and we found that this was really not feasible to ask a patient to do in the real world. So we ended up settling on 30 seconds as like a happy medium. We wanted to get enough sweat onto the paper, but we didn't want to make it like so awkward that no one would ever want to give a fingerprint. So we also had a look at the fact that we see large variation between the fingers from the same hand, for example. And one of the things that we thought would be the most useful for this is hand washing. So we also talked about this for removing contamination, and this is that's really good for illicit drug testing, but in trying to reduce variation, it's really useful to make all of the fingers more consistent. By introducing a hand washing stage, you're able to remove everything off the hand, allow them to sweat for say 10 minutes, and then collect a sample. And then your sample is more representative of the time of collection rather than just an accumulation of what is on the fingers, either from themselves or from contact over the last how many hours, minutes since they last washed their hands. So here you can see in this graph, using creatinine again as just a marker of how much sweat has been put down, we're able to see that this person here, background 1, their index and middle finger are quite low, but for some reason their ring finger has either come in contact with something or has just a higher level. They haven't washed it as well perhaps. And then you can see that there's a large difference between these 3 fingers, and by introducing a hand washing stage and waiting just for 10 minutes before collecting the samples again, we're able to reduce the variation between the fingers. So taking this forward, we decided to implement this with our patient group. So one of the things that we also came up against was large variation even after controlling all of these different parameters. And we were thinking, well, in the case where we're looking for adherence, is it that we can't see a drug because the patient isn't taking their drug, or is it that we can't see a drug because there isn't enough sample there? And one of the things that is really difficult here is that we are already looking at such low volumes that either even just a slightly lower volume can sometimes push us below our limit of quantification. So we're trying to think about how can we ensure that we're not incorrectly accusing people of not giving, of not taking their medication without first verifying that we actually have enough sample. So in this study, we recruited patients with tuberculosis, and they were receiving isoniazid as treatment, and we also recruited a negative control group for comparison. The collection conditions were controlled, as I've discussed, so we controlled time, we controlled deposition pressure, and we also implemented a hand washing stage, but we still saw significant variation in the metabolite of acetyl isoniazid, which is the metabolite of isoniazid. And we were thinking, well, we need to make sure that if we can't see the drug, it's not because the patient isn't taking the drug, it's because either our test isn't good enough or there isn't enough material. So we used Tracefinder software, which is the software that you can use to go back and look at data, and you can see what other components are in your sample, not just the ones that you've been targeted towards. And we looked for metabolites that are known to be in eccrine sweat. So we found that when we saw these markers that we would expect to be in sweat, so we've got lysine here, we have ornithine, we have taurine, and we also have pyroglutamic acid down here. We saw that when we saw these markers, we also saw the drug. So we were thinking, well, this could be a way of verifying whether we have enough sample. So for example, we have 2 different donors here, donor 33 and 38, and these are drug users. So we were expecting to see the drug, and you can see that when we have high levels of these markers, we also have high levels of the drug. Examples of poor donors would be where we can't see any of these markers at all, but we also can't see the drug. So the reason that we're not seeing the drug is likely because there is not enough sample down on the piece of paper, rather than the fact that the patient isn't taking their drug, and we would need to repeat the sampling to be able to verify the result. And finally, we did a negative control group, and you can see that we can see these markers, but we can't see the drug as expected. So we decided that by implementing this sort of phase of looking for these other components, we were able to remove samples that are not valid for our test. And we found that our accuracy based on looking at the metabolite of isoniazid increased to 100%. So going from here, we thought, well, perhaps we can use these markers for something else. Can we make our test better by, using it as perhaps something to measure how much sample is down there, not just is there enough, is it applicable to say there's this much sweat, therefore the concentration of drug is this. So the first sort of phase of this was to see whether even looking at this would make sense. So we filtered our data to remove the patients who had insufficient sample, and this reduced our variation down here to a smaller spread. And then we decided to look at how the variation of between the fingers changed by normalizing instead to just a internal standard to also a internal marker. So here in this graph, you can see that normalizing to an internal standard gives a CV of ranging between, say, 20% and 150%. So this is terrible. So we've got really large differences between fingers from the same individual. Then if we take normalization to taurine, we're able to reduce the variation in every case. So each donor found their variation to decrease when we normalized to an internal marker. And this managed to decrease our variation overall. So that's kind of what we're looking at these days. The focus of my PhD is looking at trying to develop this drug level. And the most promising thing that we've looked at so far is using the internal markers to reduce the variability, and we're now working towards trying to produce a drug level. So in collaboration with the University Medical Centre in Groningen, with University Hospitals of Leicester and also Friendly Health, we're looking at tuberculosis drugs. With the Epilepsy Society, Friendly and UCLH, we're looking at anti-epileptics, and we're also continuing our collaboration with Surrey and Borders Partnership to look at antipsychotics. And now what we're doing is we are comparing fingerprint samples with other matrices. So we're collecting paired samples of blood and also saliva, and in some cases sebum, to see whether we can see the levels in these matrices and see if it in any way compares to what we're seeing in fingerprints. And also trying to see whether, if we use these internal markers, are we able to develop a drug level which is indicative of how much drugs in the system. So in conclusion, we're exploring non-invasive patient sampling to reduce burden on patients and clinicians using fingerprints. The information that we're able to get from fingerprints and drug users is relevant for adherence testing, but so far we have successfully developed qualitative tests. But if we want to move towards more quantitative testing, it's important that we investigate perhaps internal markers and looking into the comparison to blood to develop a drug level. So I have my contact details down here and also my supervisor's contact details. So if anyone's interested in collaborating or has any really clever ideas about how we can make our technology even better, then I'm sure we'd be happy to talk to you about that. And just a quick shout out to Mel, Katya, Mahado and Cecile at the University of Surrey, who allowed me to use their data in this presentation today, and also to our other collaborators. Thank you.